Hello. Good evening, students. Good evening. From where we are streaming, we'll just see whether we are live or not. Can I get a thumbs up confirmation whether we are live or not? Yes, I think we are live. Yes, I think we are live. Yes, so can I also get to know in the chat box if uh, the chat box everything is working or not? Just a second. If yeah, Minakshi, yeah, thank you. Thank you, Rin. Yeah, so I think the chat box and everything is working. Yes. Good evening, all of you. Good evening. Welcome, all of you, to our session. Just a quick couple of points before we begin. So all of you are aware of the Unacademy NEET PG section. Very important. Okay. Download the Unacademy app to get all the information. What are we having? We are having this mission INI-CET rapid revision batch, which is starting, and in 2 months we are going to cover the entire portion. Most important highlight for this, all the best teachers are going to be there. The promo code is mentor. Okay, so mentor code gets you the subscription at only 3149, and use that. And also for NEXT or the NEET PG upcoming exam also we will be there, and the code remains the same, mentor. Okay, so any subscription, the code is the same, mentor. And I would want all of you to enroll and see the lectures. That's really going to help you out. Okay, along with this fabulous results in this NEET PG, also the ranks, rank 3, rank 63, rank 16, rank 81, all these secured through our coaching, and students have done really well so please start your preparation. You can even go for the 6 months to 9 months package. Okay, and starting from 28 March you are going to get this 9 months. You are getting 2 months also free subscription on 9 months and above. Okay, what are the advantages? Live classes, recorded classes, anytime, anywhere, best teachers and notes. And most important, what I would want to tell you, Iconic is of course available, combination of both prep and Unacademy. But the most important which I would want to tell you is Vitals. You have to see students are loving it. Completely pre-recorded studio recording, superb quality, 800 hours by all the best teachers including me for OBGYN. So there's a special category called as Vitals in the Unacademy app, which all of you should see the videos and subscribe for it and go. And these are extremely cost effective, all 19 subjects. Okay, all 19 subjects. You can go for 6 months or 9 months. They are available at extremely low cost. It's depending on the student's requirement. 6 months, 1 year package are available. So NEET PG Vital complete set of pre-recorded lectures which is available. You can see anytime, anywhere, and notes also will be added very soon for all of you. Okay, and of course these batches which I have already told you, and raise the hand is a feature. So just download the Unacademy app, you'll get all the information. And with this, let's start our discussion. Like every time, keep it as a interactive thing. Ask the question, answer the question when we guess. These are the most important expected INI-CET MCQs. Okay, and one more thing, again on Tuesday, okay, after 2-3 days, today is Saturday, again on Tuesday at the same time, 5:30 p.m. I have got one more free class on the YouTube channel. Okay, so I invite all of you for this also. This Tuesday, which is 28th, I will see you again 5:30 p.m. Okay, so Tuesday 5:30 p.m. for one more set of MCQ discussion videos. Okay, so don't miss out this session for sure. Okay, it's on Tuesday, so it will be 28th. Yeah, 28th of this month. Okay, yes. So let's start, and like always, all of you please do participate, and all of you answer the questions. Okay, let us start. Yes, so first, so these are all the extremely important high yield topic, hot topic, as you would want to say, clinical cases and the questions for the INI-CET mainly, but of course for FMG also. So whichever year you are, you get the benefit. Yes, so anybody, what have I got over here? We have got a lady who has come to us with a history of recurrent abortion, 8 weeks, 11 weeks, and with early onset preeclampsia also in the next pregnancy. Which do you think is the most probable cause? Now, can anybody tell me? Very good, Zoradian, Swantana Verma, Monica, Divya Shri, all of you. Now, can anybody tell me why option number A is not the answer? Why option number A is not the answer? Because you know we discussed not only the main topic, the also the other associated topics also. Cervical incompetence will always cause abortion in the second trimester. Okay, T2. Yes, Monica, perfect. Okay, here all the patients, abortion 8 weeks, 11 weeks are in the first. Cervical incompetence repeated painless mid trimester. Okay, so keep in mind, cervical incompetence always causes mid trimester, or that's your second trimester abortion. So that's out. Again, please understand, GDM. Will GDM cause an abortion? No. GDM, anybody, when does the GDM develop? And TORCH gives you repeated once TORCH. So TORCH cannot cause repeated abortion. TORCH can cause one miscarriage, never implicate TORCH. TORCH is a test which we never do in a patient of repeated miscarriage. That also could be a difficult MCQ. Once time you get a TORCH infection, you will not get it again because it gives you lifelong immunity. Gestational diabetes develops only at 24 to 28 weeks of gestation, generally most of the time. So again, that is not the answer, and perfectly correct. The answer is antiphospholipid antibody syndrome, APLA syndrome, or any of the thrombophilia, basically thrombophilia. Okay, so thrombophilia could be your hereditary or acquired thrombophilia also. Hereditary thrombophilia is our protein C, protein S deficiency, factor V Leiden mutation, and APLA syndrome. Now, before we proceed further, yes, very good, Diveshri. Dark Night, we're coming to the treatment in a minute. Can anybody tell me what are the 5 manifestations of APLA syndrome? APLA, say 1, 2, 3, 4, 5. By heart, all of you should know. 1 is miscarriage or abortion, what this patient already had. Okay, what else? What else APLA syndrome can cause? Yes, severe preeclampsia, and that also early onset. Okay, early onset matlab ke patient can normally preeclampsia normally preeclampsia is at after 20 weeks, but most of the time it's still at around 27-28 weeks. Here preeclampsia happens early by 20 to 24 weeks. Then severe IUGR, and what else? We also, there's a risk of IUFD, sudden IUFD. Yes, very good, DK. And lastly, even abruption. So these 5 things you should know by heart. Okay, I repeat, miscarriage or abortions, severe early onset preeclampsia, IUGR, IUFD, and also abruption. Okay, yeah, but help is okay. Help could be a part of preeclampsia only, but okay. So this is the feature of APLA syndrome, and yes, we also would want to discuss the treatment for it. So anybody, now next MCQ to help us give the treatment. So we have a patient who has come to us, gravida 4, abortion 3. So previous 3 miscarriages, that's because of antiphospholipid antibody syndrome. And what do you think is the treatment for this patient? Somebody said aspirin. Anything better than aspirin? Yes, very good. Vitamin B12 does not help. Vitamin B12 only helps if there is hyperhomocystinemia. Warfarin, when do you give? Will explain to you. Aspirin and low molecular weight heparin, that is the answer. Excuse me. The main treatment is heparin, and when we give heparin, all this, please understand what happens in APLA syndrome is that there is, why does all this thing happen? Please understand, all of you, that the blood supply gets cut off. Okay, I'm just giving an example. Let's suppose if this is the This is the blood supply to the baby, the umbilical cord, and this is the baby. Then there is thrombosis, the blood vessel gets blocked, thrombosis is happening, it's a hypercoagulable state, and because of this there's IUFD, IUGR, preeclampsia. So when we give low molecular weight heparin along with aspirin, so low molecular weight heparin is more important, aspirin of course you give, that is going to prevent all the complication. Anybody, which condition, so that's my specialty. We not only discuss one MCQ, other important MCQs also. Which condition will I use warfarin in pregnancy? Which one condition? Vanitha, we don't use warfarin for only Apla syndrome. Warfarin is used in the first pregnancy, never in the first trimester. In the first trimester never, but there's a condition where in the second trimester we use warfarin, and that is no metallic valve. Okay, so go back and see my lectures. You need to see, yes, heart disease, Zoroastrian, but also specifically when there's a metallic valve in the patient body. When there's a metallic valve, when the patient has got mitral valve replacement. Okay, when the patient has undergone the MVR, mitral valve replacement, that is the time for you to need to give warfarin to the patient. Otherwise the treatment of Apla syndrome is your low molecular weight heparin and aspirin. Is this understood to all of you? So the answer is heparin, low molecular weight. Normal heparin is also okay, can be used. Okay, moving on. Yes, very important. I'm giving you two MCQs back to back, something similar. This was also asked in one of the recent exams and likely question for the upcoming exams also. Cervical cancer, no better doctor, DK, never in the first trimester. Okay, DK, I told you, warfarin never in the first trimester, it's absolute teratogenic drug. Okay, DK, you get Conradi syndrome and all that, that's a separate MCQ. So second trimester onwards you can give. Yes, anybody, 3B, what is the treatment? Okay, Meenakshi, hysterectomy, no, what is? Okay, look at the stage. Which stages I can do surgical therapy? Surgical management is done with which stage? Okay, simple hysterectomy out. Wertheim's hysterectomy. Please understand, this word is very famous. Wertheim's is another name for modified radical. Okay, Wertheim's is also called as modified radical hysterectomy. What is it? Please understand the surgical management. The surgical management, that is your modified radical hysterectomy, is only for stages 1A, 2, 1B and 2A. That's it. I repeat, 1A, 2, 1B, 2A. Is this understood to all of you? Can I get thumbs up? Okay, beyond this matlab stages beyond this, 2B, 3, 4, all 2B onward, because till 2A acceptable hai. 2B, 3, 3A, 3B, 4A, 4B, all is what? Yes, radiotherapy, only chemotherapy out, and therefore radiotherapy is the answer. But okay, now see this MCQ. I'm so happy we teach every year in the lectures, and this came also 2-3 years back in the INI-CET. Now can anybody tell me? So okay, so this is RT, I'll explain to you more. And now tell me, same question. Array sir, question is the same. Is the same question? Yes, question is absolutely the same, but what have I changed? We have changed the options. Yes, excellent all of you, excellent all of you. Now here again, simple hysterectomy out, Wertheim hysterectomy out, only chemotherapy is wrong, only chemotherapy is not there. And when I have to choose between D and E, concurrent chemoradiation is the answer. So please don't make a mistake in this. Okay, I'll explain to you what is this. So here it is mainly radiotherapy, but cisplatin is given to the patient before radiation, and therefore it's called as concurrent. Yes, cisplatin, very good Shiva, excellent. Cisplatin is given to increase the radiosensitivity, it's given as a radiosensitizer, and therefore the word used is CTRT, concurrent chemo, or sometimes the word used is only chemoradiation. Is it understood to all of you? So whether you call it CTRT or concurrent chemoradiation or chemoradiation, that is the answer. So when radiotherapy, this students made a mistake, and therefore please understand this, I will settle this, that stages 2B, 3, 4 are inoperable and radiotherapy is the answer. But if CTRT is in the option, CTRT is a better answer. Okay, is this understood to all of you? Only CT is wrong. Is it clear? Only chemotherapy, no role. Chemotherapy is mainly the role in ovarian cancer. Okay, epithelial, for ovarian malignancy, for ovarian cancer, we use post-operative chemotherapy. Is this understood to all of you? 10 thumbs up. So cervical cancer is actually radiotherapy or CTRT, which is what you need to keep in mind. And remember this, that stages which are operable 1A to 1B, 2A, we can go ahead with this, and 2B, 3 and 4, 4A, 4B all are inoperable, and therefore they will be treated with concurrent chemoradiation. Excellent, all of you. Let's proceed further to the next MCQ. Okay, yes, now what is this? I hope it's absolutely clear to all of you. The karyotype is given, okay, and you might have just zoom in your screen. I have had a big picture, but still, yes. What is the question given to you? We had a similar question discussion our last time's YouTube session also. We have got a primary amenorrhea, absent uterus, and along with it, can anybody see the karyotype? What is the karyotype which is shown to you? Yes. Yes, perfectly correct. So all of you correct, and the karyotype shown to us is XY. XY. So which, and it's of course 46. So 46 XY. We give you this answer in a minute, and along with it a very famous type of a question for the INI-CET is your match the column. So can anybody now give me this? We are giving the answer to this. I'm giving you the answer for this in a minute, but can anybody tell me about the match the column also? Just a second, slightly a lag. Yes, perfectly correct, all of you. Yes. Okay, so perfectly correct. Turner syndrome, all of you know, 45XO. So one is going with A. So already these two are out. Perfectly correct. These two both are out of our option. RMKH is what? RMKH is 46XX and AIS is XY. Okay, this is the answer also over here. Androgen insensitivity syndrome. Androgen insensitivity syndrome, this is the answer. Primary amenorrhea, absent uterus, and because this is a Y chromosome, so 46XY दिया है, therefore this is the answer. I repeat, RMKH is 46XX. Okay, yes. And so 1A है, 2C, 3B and 4D, Klinefelter 47XXY. So very good. Option number B. Yes, Pisces, Dhanashree, all of you, DK, all of you correct. That is the answer. Okay, is it clear to all of you? So let's move on to the next question. And so this, okay, so karyotyping is very famous. Match the column, don't make a mistake in this. Moving on to the next question. Yes, very, very famous. Hysteroscopy, laparoscopy. Hysteroscopy indicated in all of the following except. Yes, no, Vijay Kumar, B nahi hoga. Yes, we'll discuss. Okay, yes, perfectly correct. All of you. Hysteroscopy and laparoscopy. Hysteroscopy is putting in a telescope inside the uterus. When do I do it? Whenever we suspect any problem with the cavity. Okay, so when cavity of the uterus, cavity or endometrium. So anybody, menorrhagia? Yes sir, a polyp could cause menorrhagia. A submucosal fibroid could cause menorrhagia. So definitely when a patient, hyperplasia will cause menorrhagia. So whenever I have got a patient of menorrhagia, we will or we can do or we should do a hysteroscopy. Infertilities, all these things, a polyp, a fibroid, a septum, all this can cause infertility also. How they prevent implantation? All this problem with the cavity would prevent implantation. And of course adhesions, which is our Asherman syndrome. Okay, intrauterine adhesions, Asherman syndrome. So all except Asherman syndrome, hysteroscopic adenolysis, menorrhagia, infertility. Answer is adenomyosis. Anybody, what we do for adenomyosis? Ultrasonography, or sometimes it required MRI. Okay, ultrasound. What is the appearance? Your radiology teacher will teach you. What do you get in adenomyosis and ultrasonography? Any idea? When I look at adenomyosis on ultrasonography, what do we get? We get glands. Okay, we get cystic spaces or glands within the myometrium. Okay, yes. So what is, yes, what anybody, what is it called? Okay, so we get that Swiss cheese appearance of multiple glands. Okay, glands, hypocystic glands within the myometrium, and Venetian blind. Yes, Venetian blind appearance you need to keep in mind. And fuzzy, like the endometrial myometrial junction, there is a problem. Okay, so the endometrial and the myometrium junction jo hota hai, yes, very good Madhusudan. Endometrial myometrial junction, junctional zone is not clear, and Venetian blind, perfectly correct Madhusudan, DK, all of you. Okay, so for that adenomyosis we require a ultrasonography or a MRI. So don't make a mistake, they're very very important MCQ regarding hysteroscopy. Yes, again a match the column. Anybody? Because match the column type of questions you are generally getting it in your INI-CET. Very famous names of the maneuvers and which condition you see what and more. Okay, yes, anybody? Very relatively a simple MCQ if you know the names. Okay, so Vigard-Martin maneuver is for what? Anybody? Vigard-Martin maneuver is for one of the maneuvers, not of everybody, because most of the students know only Burns-Marshall. Why am I giving you this? Because Vigard-Martin is also for the after coming head of the breech. Okay, after coming head of what? After coming head of breech is understood. Okay, that is Vigard-Martin. So one is going with C. Okay, so if one is going with C, we have got only these two are out. Okay, Wood's maneuver is for shoulder dystocia, 2F. Match the column becomes easy because even if you know 2, okay, you get yes. So 2 is F and therefore 2A ye bhi out ho jata hai. Covulier uterus. When do we get covulier uterus? Covulier uterus, you get it in abruption. The uterus becomes mulberry bluish purplish in color. And McAfee and Johnson regime, okay, McAfee and Johnson regime, okay, is in McAfee and Johnson regime we do it in cases of placenta previa. What is McAfee and Johnson? Conservative management. When I wait and watch, when the patient is stable, and the conservative management which I do in placenta, PP I am writing, okay, placenta previa. Okay, in placenta previa, when I do a conservative management, it is called as McAfee and Johnson. Okay, so but a Vigard-Martin, how do you do it? You're not supposed to remember the details, but how in Morris's Melivate, you are going inside malar flexion and shoulder traction. So in Vigadmartin, it's also malar flexion, but along with it, suprapubic pressure is given. Okay, so it's a combination where you give malar flexion instead of shoulder traction. We are giving a suprapubic pressure. Okay, so that is your Vigadmartin maneuver. Okay, for after coming under breech. So yes, absolutely correct. 1C, 2F, 3A, and 4B. This option number 4 is the answer. Okay, absolutely correct, all of you. Okay, very important. Now yes, difficult MCQ, think aram se, don't be in a hurry, because all the screening for trisomy and all that are very important. I have got a patient who has come to us at 17 weeks for a quadruple marker test. Which are the 4 things what I do in quadruple marker? Tell me from there. Report shows an increase in alpha fetoprotein. So alpha fetoprotein is showing elevated in all of the following could be reasons except. So basically starting का part नहीं भी दिया है. Question is alpha fetoprotein is in all of the following except. Okay, so very quickly, can anybody tell me what is the quadruple marker test? Quadruple marker test. HCG, alpha fetoprotein. Yes, quadruple marker test is a screening test for trisomy 21. Very good. It is a screening test for mainly trisomy 21. Alpha fetoprotein. Yes, and one more, unconjugated estriol. And these are the 3. This is triple marker test. And your inhibin. Inhibin A. Is this understood to all of you? These 4. Okay, this is called as, I repeat, HCG number 1, alpha fetoprotein number 2, unconjugated estriol number 3. That is triple marker test. When I add this inhibin as number 4, that is quadruple marker test. Now this itself will give you the answer. Can anybody tell me, suppose if the baby is having Down syndrome, suppose if the baby is having trisomy 21, what happens to the arrow over here? Anybody? Should I draw arrow up or arrow down? Anybody? Inhibin A values in your this, arrow up or arrow down? HCG arrow up. Inhibin Monica, very good, arrow up. And alpha fetoprotein arrow down. T and T and estriol also arrow down, and that is our answer. If you see, alpha fetoprotein is going to be decreased in trisomy 21. Yes or no? Is this understood to all of you? So this is applied MCQ. You need not you need not have to remember. So this is arrow up, this is arrow up, this is arrow down, this is arrow down, and therefore I know that in trisomy 21 alpha fetoprotein, and that is your answer. And sir, when the baby has got skeletal defects, abdominal wall defects, omphalocele, neural tube defects, all these cases alpha, mainly remember neural tube defects, omphalocele, skeletal deformities, trisomy 21 alpha fetoprotein is going to become lesser. Is this understood to all of you? So it's a very important MCQ. Don't make a mistake in this. Please keep in mind. Yes, one more very important MCQ, because emergency contraception, definitely this topic they like to ask you. Okay, is it understood to all of you? Okay, so please keep in mind, in trisomy 21 the alpha fetoprotein is lesser than normal. Alpha fetoprotein, it's called as maternal serum. Okay, maternal serum alpha fetoprotein, we call it as maternal serum alpha fetoprotein. Yes, which can be used which of the following can be used up to 5 days? Why all of the above is not the answer? Very good. Can anybody tell me LNG 1.5 milligram? LNG 1.5 milligram can be used only up to 72 hours. Okay, and the answer is ulipristal 30 milligram. Very good. 30 milligram single dose is the answer. Can be used up to 5 days following sexual intercourse. Any other thing up to 5 days? Very simple. Any other thing which you can use up to 5 days? IUCD. Okay, IUCD is also can be inserted up to 5 days. And why misoprostol is not the answer, anybody? Because misoprostol we use for, yes, all of you correct. Med Devo, Vijay Kumar Singh, Shivam, all of misoprostol kahan pe use? Misoprostol is for what? Misoprostol is for MTP, that is after the pregnancy is confirmed. Okay, students, so don't make a mistake. Meso is even for MTP. Don't confuse. And this is question is about emergency contraception. Emergency contraception, MTP is not the same thing. Both is not the same thing. Okay, so misoprostol is only for MTP, and of course PPH and all that other uses of that other meso are very important. We discuss in the actual classes. You need to listen to that. Okay. Yes. Now, very famous HSG, routinely asked to you. Interpret the HSG given to you. What it is? Is it a normal HSG, bilateral blocks, left block, right block, bilateral femurial block? Yes. So understand, students, that when we see a normal HSG, we see the triangle uterus and we see the fallopian tubes. We see the fallopian tubes and we see the spill of the dye. What is this called as? Spill of the dye. That means it is normal. But here what we are seeing, sir, I'm seeing the uterus, but the fallopian tube is not seen only. Can you see this? The fallopian tube part. The fallopian tube should have been seen like this, that is not being seen. Okay, the fallopian tube is not being seen, and therefore we are only seeing the outline of the uterus. Fallopian tube nahi dikh raha hai, and that is because it is not a bilateral cornual block. Anybody, what should be the next step for this patient? So it's not only left and right block. And anybody, how will be a femurial block seen? One MCQ, 3 more MCQs. Femurial block mein kya hoga? Femurial block, you will see the dye all the way entering up to the femurial end, and then the spill will not be seen. That is called as a femurial block. And generally in femurial block, the tubes are dilated. Yes. No, Abhishek Malhotra, you don't repeat. It could be, yes. So it's not a physio. Yes, it and this is a femurial block. Okay. So when I don't see a block, and there is a hydrosalpinx. Okay. So you need to confirm. Yes. Do not directly go for IV, but the block. It could be a block or it could also be a spasm. It's very difficult to differentiate whether it is actually a block or a spasm, and therefore you should go for the confirmatory testing. And what the confirmatory testing? What is the confirmatory testing? Yes, piece is correct. It could be a spasm, and therefore we get this picture that, sir, only the uterus is seen and the dye is not seen. So kya karenge? How do you confirm? It's a confirmatory testing. The confirmatory testing is to do a chalo, what is the best test for tubal patency? So you never repeat. Okay, Abhishek Malhotra, again no point repeating HSG. Again you will get the same picture. So kya karoge? Okay, HSG is an initial test. What is the best test for tubal patency? Yes, Madhusudan, that whenever HSG is having a doubt, I should do a laparoscopy with chromoperturbation. Okay, so we discussed as an entire lecture on the test for tubal patency. Okay, laparoscopy with chromoperturbation, which is done with a methylene blue dye. Okay, methylene blue dye एक होता है, which also we will be discussing in the image based sessions also. Okay, so with a methylene blue laparoscopic coordination, that's a confirmatory. So very good. Since only so femurial, this is how the option E will look. Okay, option E, bilateral femurial block will look like this. There's a block here, block. This is bilateral cornal block, or yes, it could also be a spasm. Moving on. Yes, very important MCQ, identify the true statement, because we have these two hormones, FSH and AMH. What are these hormones for? FSH and AMH. How does it help a female infertility investigation? These are tests for what? Anybody? FSH and AMH. Very good. There is something called as a concept of ovarian reserve, which is very important. We were teaching this since ages, and this question came around 3-4 years back. Almost all students clean board. Very good. So ovarian reserve tells you the capacity of the ovary to produce eggs. Okay, FSH comes from the pituitary gland, pituitary, and AMH is from the ovaries itself. And the important part is AMH can be done on any day of the cycle. AMH values remain the same almost throughout the month. So AA, easy to remember, AMH any day. But FSH should always be done on day 2 or day 3 of the menstrual cycle. Is this understood to all of you? Okay, it should be done on day 2 or day 3 of the menstrual cycle, and therefore the answer to this is both have to be done on day 2. Wrong. Both can be done on any day. Wrong. FSH on day 2, day 3, AMH on any day. Option B is the right answer. All of you correct. Okay, AMH not on any. Okay, is this understood? Why? Because as the cycle will produce, as the cycle produces, goes ahead, we get a falsely elevated. So remember, FSH is again a very important MCQ. FSH should always be done on day 2, day 3. Okay, day 2 or day 3 of the cycle. It means when the menses start, the next day. Okay. And we'll also discuss the values of FSH and AMH when there is ovarian reserve is diminished. Okay, so that all of you get it, because there's one more MCQ related to it, which I will discuss in some time. Yes, this is the MCQ. Chalo, very important, difficult clinical case based MCQ. 30-year-old patient, 11 weeks pregnancy, had an incomplete abortion. So she underwent a check curettage, and then she has come with, she has not yet got her periods. Okay, 4 months after that, and we are adding to that UPT is negative. Okay, I'm giving you extra information that the urine pregnancy test is negative. So after, because that's secondary. Okay, so 4 months after the miscarriage, she still not had got her period. She is having amenorrhea. So pregnancy I have ruled out. And now I have found out that the FSH is 5. Now all of you tell me before, yes, we'll discuss this in a minute. Can anybody tell me this FSH which is given to you as 5, is it less, normal, high, or what is it? What's the normal FSH? FSH 5 given in the question paper. Is it less, high, or normal? It is normal. Yes, Arun Sharma. Yeah, 5 to, मतलब 3 to 10 पकड़ सकते हैं. 20 is on the higher side, Arun. 14, 15, 20 definitely high. So 3 to 10, all of, no, 3. Okay, 3, 4, 5, 6, 3 to 12, 3 to 10 के बीच में अगर है तो we can consider. 10 के बाद definitely it's on the higher side. Okay, so it is a normal. Okay, now suppose, I'll give you the answer to this in a minute. Suppose if I change this question and the FSH 5, if I make it FSH say 35, FSH is 35. then what do you think is the answer? FSH 35 or FSH 45, then what do you think is the answer? Yes, excellent, Monica. So that is what I want to tell you, that please understand this, that this concept of MCQ, that as the servant, master and servant relationship you need to discuss and keep in mind. Pituitary is the master, okay, and ovary is the servant. So when the ovarian reserves becomes less, FSH keeps on rising, because master has to shout more loudly कि पापा काम करो, and when the ovarian function is completely over or stop, it could be natural, that is natural menopause, or if it stops early we call it early menopause. But whenever the ovarian function completely stops, FSH will be the highest. Therefore FSH is highest when the ovarian function stops. Is this understood to all of you? So highest FSH we get in menopausal ladies or postmenopausal. So if the MCQ FSH is anything, say 20, 30, 45, that means it is ovarian failure. Pituitary failure, what will happen to FSH? FSH will become very low. Suppose if the value is 0.1, 0.2, 1, anything less than 1, okay, then you know that it is the pituitary. And uterine, intrauterine synechiae, the FSH is normal, okay, that is the reason. So 3 MCQs can be given to you as a part of this. When we come back to the original MCQ, since FSH is 5, which is normal, the answer is intrauterine synechiae and a curettage. The curettage may be responsible for this, and therefore intrauterine synechiae, the FSH is going to be normal. I repeat, the ovarian failure, FSH will be very high. Pituitary failure, FSH will be very low. Is this understood to all of you? And can anybody tell me what is the most common cause for secondary amenorrhea? Because this is secondary amenorrhea, yes or no? This patient who has had an abortion, so she has conceived once and now she has got amenorrhea. So this is secondary amenorrhea. What is the most common cause for secondary amenorrhea? Yes, pregnancy. No, beta, not Shians. Okay, Priyaraj. Pregnancy is the most common cause for secondary amenorrhea, and therefore I had added that in this question. UPT. Anyway, pregnancy is not in the option, but you need to rule out, and UPT is negative. That's what I had added to this in the question. That UPT is negative, for pregnancy is out, and therefore any of the above nahi ho sakta hai. Is understood? So very high FSH. Ovarian failure, very low FSH. Pituitary failure, normal FSH. Looks at your intrauterine synechiae could be the answer. Yes, again a difficult clinical case based MCQ. What have I got? We have got a patient of gestational hypertension. Comes to us at 28 weeks. Since 32 weeks, pain in abdomen, pulse high, BP low, hemoglobin less, definitely. Uterus 34 weeks, tonically contracted, clue, and IUFT. So yes. So why is the patient going in shock, and what will this give rise to? Abhi discuss kiya. Okay, one more. Okay, so perfectly correct. The patient has gone in shock. That is because she has abruption. The placenta detaches from its attachment. Placenta detaches. Baby is still inside antepartum, but the blood is not able to come out. All the blood is getting collected behind the placenta. We call it as retroplacental clot. retroplacental clot will be seen, big clot will be coming out, retroplacental blood gets collected, okay, and that is because it is concealed abruption. That is the answer. All of you correct. Why? Because on PV examination no bleeding seen. That is the concealed. Revealed में you will see bleeding. Revealed में क्या होगा? Bleeding will be plus plus plus. Lots of bleeding will be seen in revealed abruption when I do ARM. Okay, and here hypertension, high blood pressure, preeclampsia is one of the risk factors for development of abruption. Is it understood to all of you? Yes. One more thing, and this is the kind of thing where you can get a cochlear uterus. Okay, so cochlear uterus comes with bluish purplish in color. Okay, and anybody what's the treatment for cochlear uterus? What is cochlear uterus? Anybody? Can anybody tell me what is the cochlear uterus? So this is the uterus. Okay, whenever the placenta detaches and there is blood, the blood glows retrograde. This blood which is happening, the blood which is here enters in between the myometrial fibers and the uterus starts appearing bluish purplish in color. So the uterus starts appearing like a bluish, mulberry uterus बोलते हैं या purplish. Anybody what's the treatment for this? It is nothing but the blood. Chalo, what's the treatment for cochlear uterus? You don't have to call the OT staff and tell, okay, sister, bring Surf Excel, Nirma washing powder, or dho dala hai. Do I need to remove all this blue color? No. So it's a diagnosis which I only make when I have opened up the patient for LSCS. Okay. Only at the time of LSCS I make this diagnosis. The uterus appears bluish purplish in color. Nothing to be done. If the uterus is very well contracted, you don't have to do anything. You just have to, no, never, S, wrong, hysterectomy, never, please. There is no need to remove. Very common mistake. Students say, cochlear uterus, remove the uterus. No, no need to remove the uterus. Is this understood to all of you? No need to do hysterectomy. Never. Never go for hysterectomy. Yes, if it's a atonic PPH, that's a separate story. If it's causing atonic, otherwise you just have to wait and watch. The color will go back, come back to its normal on itself. Yes. Okay. Yes. Yes. Again, a very important MCQ. Which of the following is a screening test in the second trimester for aneuploidy trisomy 21 except? So please understand, all these are hot topics. Contraception, infertility, antenatal screening for trisomy. So you need to know questions on this. Excellent, all of you. Arjun, Snowcast, Abhishek, essay. Yes. अभी बता दिया sir, HCG, alpha fetoprotein inhibin, all are done in the second trimester. HCG is also in the first, but PAP-A is a part of dual marker test and PAP-A is done in the first trimester. PAP-A is a part of dual marker test. And dual marker test is done in the first trimester. Similar MCQ, anybody? Yes, again very good. PAP-A is done in the first trimester. Yes sir. HCG is a part of dual marker. NT scan is also done at 11 to 12 to 13 weeks. The answer is chorionic villus sampling. Why? Sir, chorionic villus sampling is done in the first trimester, but it is not a screening test. Chorionic villus sampling is a confirmatory test, because with chorionic villus sampling we get to do the Karyotyping. Is this understood to all of you? So please don't make a mistake in this topic. Chorionic villus sampling is a confirmatory test which I will do in the first trimester if there's a problem. Okay, so it's a confirmatory testing because it's a karyotyping. So therefore this is because all are screening tests except chorionic villus sampling. Okay, that is the answer D. So here option A is the answer because option A is done in the first trimester. Here D is the answer. Yes. No, beta Dr. S. NT is nuchal translucency always. There's a separate thing we call nuchal fold thickness. Okay, nuchal thickness is also different. Both are there. Nuchal fold thickness, we do it in the second trimester. T2. NT is nuchal translucency. That is done in the first trimester. When I say NT, it is always this. Okay, is it clear? Yes. Now, magnesium sulfate. Very, very important. We should know about magnesium sulfate also. Pritchard protocol for MAXELF. All of you know we give it for convulsions, eclampsia. Monica, C. No, C is wrong. Why C is wrong? D is wrong. Clean bold, all of you. Yes. So remember that the dose is in the form of grams and 14 grams. 14 gram. But A और B में से क्या choose करना है? Yes. Perfectly correct. Monica, Kumari, Beauty, Madhavi and Arakdeep Adhikari. Yes. 14 gram is the loading dose. By loading I mean when there is a convulsion. Okay, so we give 4 grams IV and then we give 5 plus 5 IM in each buttocks. Okay, and therefore 14 grams, 4 gram IV, 10 gram IM. This is the answer. Okay, do not confuse this. ये नहीं है. Okay, one more MCQ. What is the therapeutic range of magnesium sulfate? What all things do I monitor when the patient is on magnesium sulfate? And what is the antidote if there is magnesium sulfate toxicity? Yes. MCQ which had come similar last time. Patient had pre-eclampsia, magnesium sulfate given. Vrutik, I am not able to understand partly your comment. I'm not able to. Very curious. What Kharak? I'm not able to. You just type it better. I'll give you the answer. Yes. So what is this? What is this? Yes. So please understand this. That here, ये सब ना lot of फालतू. They give you this question. So big question. Patient is on magnesium sulfate. उतना देख लिया. Okay. Knee jerks absent. Finish. Bus. Okay. Knee jerks absent. Okay. Is this clear to all of you? So what it is? So that is what you should know. And also, okay, respiratory rate is also lesser. Okay. Respiratory rate is 10 per minute. So depressed respiration, knee jerks absent. This is magnesium toxicity. Perfectly correct. Okay. So remember students that whenever we give magnesium sulfate, 3 things. The therapeutic range to maintain is 4 to 7 milli equivalents per liter. Okay. Is it understood to all of you? That is one MCQ. And 3 things what we monitor is knee jerks or deep tendon reflexes, respiratory rate and urine output. Okay, urine output should be how much? urine output should be how much? It should be at least 25 to 30 cc per hour. Is this understood to all of you? Because if the urine output is less, magnesium will get accumulated and maximal toxicity, and then the deep tendon reflexes are abolished and respiration gets depressed. That is a sign of magnesium sulfate toxicity. Therefore this is the answer, and all of you correct the antidote calcium gluconate. Is the drug of choice for magnesium sulfate toxicity. Okay, yes. Now tell me this, what have I got? You got time for this? Okay, we have got a primi gravida. She has come to us at 32 weeks. Fetus is in breech position. Okay, EBW 1.8, AFI 38, respiratory distress to the mother, not to the baby. Huh? Mother has respiratory distress. Best treated by. Snowcast B. बेटा मैग्नीशियम सल्फेट देके क्या फायदा होगा? No point. What is magnesium sulfate going to do over here? No. Okay, so yes, some are saying C, some are saying E, some are saying D. Okay, so very good, nobody is saying it. So this is what? Basically this is polyhydroamnios. Okay, this is polyhydroamnios. The patient is 32 weeks and AFI is 35 centimeter. It is severe polyhydroamnios which is causing marked respiratory distress in the mother. Mannitol is not going to help you, and furosemide helps you when there is pulmonary edema. Yes, no cash, no problem, Mr. Miss. Yes, okay. And magnesium sulfate, no role over here. Okay, magnesium sulfate we give it if there's eclampsia, pre-eclampsia, all that, or impending, not over here. Here we are only 32 weeks, so you will have to do amniocentesis. Here it is a therapeutic. Okay, just to tell you, it's a therapeutic, not which I do for 18-20 weeks or trisomy 21. Therapeutic, we poke in the needle and take the fluid out to help her with the respiratory distress. Okay, and ARM I will not do at 32 weeks, because when I do ARM, that means I have to go for the delivery. Okay, then there's labor. So if this 32 weeks, please understand this, if this 32 weeks, the question is 37 weeks, then yes, the answer is option D. Are you understanding, all of you? See how one word. Okay, so if even your one of the word changes, if instead of this 32 weeks we have got say 37 to 38 weeks, then the answer would be controlled ARM. Controlled matlab ke you don't allow suddenly all the gush of liquor, because there is sudden gush of liquor, there could be abruption, cord collapse. So controlled ARM is the answer. But when ARM is done, because now after 37 weeks you can deliver the patient, you can go with the delivery. Okay, is it understood to all of you? External cephalic version is for breech. That's not the point over here. We are only 32 weeks. So breech, rotation, all that business is not what they are asking you. Okay, and breech is there given just by the way. So breech is just given to confuse you. Here we are going to do amniocentesis because patient is only 32 weeks. So diagnosis poly with marked respiratory distress and this. Okay, yes. Yes, and the last question we will have, very important. Yeah, magnesium sulfate before 32 is neuroprotective, correct beta, but that is for the baby, that is if you're planning a delivery. Okay, yes, if there is a delivery which is surely bound to happen before 32 weeks, then definitely give magnesium sulfate to the mother for neuroprotection for the baby. Okay, that is if the patient is in preterm labor or you're inducing early delivery. Yes, what have we got? We have got diabetes in pregnancy. Gravida 3, para 2, living 2. She has now come to us at 36 weeks. Chalo, all of you, very very famous MCQ. A, B, C, D. Yes. Now, anybody, what is the danger in diabetes if I wait till 40 weeks? Specifically, insulin dependent diabetes till 40 weeks, there is a risk of IUFD, and therefore no Arakdev and 3 you and Vijay Kumar 3 nahi beta. Okay, you will not wait till 40 weeks. Risk of sudden IUFD. No, macrosomy is okay. Baby will become big and big, and here remember, it is always advisable that when I have diabetes, we should plan the delivery between 38 to 39 weeks, because at 40 weeks there is a risk of sudden IUFD. Okay, sudden IUFD can happen, and therefore never wait till 40 weeks. Is it clear to all of you? So now again, no. So this 40 is out, all of you know. And how has she is both, all of you read this, she has previous 2 deliveries of the baby by LSCS. So when she is previous to LSCS, all of you tell me, is VBAC possible, vaginal delivery possible? No, never. So option 2, will patient should be induced by 38 weeks? No, we will have to go for elective cesarean at 38 to 39. Is this understood? Yes, there's a risk of prematurity is always, because this poly beta. If there's poly, there's a risk of prematurity. Okay, is it clear? Yes, no, cash option A correct. Is this understood to all of you? I repeat my point that here she is, please see, she has 2 deliveries by LSCS. So she is a patient of previous to LSCS, and therefore now I will again have to undergo LSCS only. Vaginal delivery is not possible. VD I am writing, VD will not happen. So option 2 out, option 4 out, 40 weeks out. The answer is we will go for LSCS at 38 to 39 weeks of gestation. Is this understood to all of you? Why 38 to 39? Because sir, at 40 weeks there is risk of sudden IUFD. Okay, had this been a primary patient or previous both vaginal delivery, then I would have induced the labor. Okay, if previous both, okay, if previous both were vaginal delivery, then answer would be option number 2. This is understood to all of you? Yes, because in previous both vaginal delivery, now vaginal delivery is possible, but 38 remains the same. 38 to 39 you have to deliver. Okay, so I hope all of you had a great time today. These are some of the very important. I think go back and check. We've discussed almost around 14 to 15 MCQs what we've discussed in this short span of time. Do follow me on the Unacademy app so that all of you get an idea. Okay, and we are keeping the quizzes and this also, and mentor is the code to take the subscription. Thank you all of you for your love and appreciation. Spread the video, and we are going to again have a session for all of you. And don't forget the vitals, superb lectures, pre-recorded lectures, and on Tuesday evening. Okay, Tuesday 5:30 p.m. Tuesday 5:30 p.m. we are again going to have one more session. Yeah, thank you all of you. And Tuesday 5:30 p.m. do join in for one more MCQ session. It's on YouTube and it's completely free. And do so follow me on the Unacademy community so that you get the notification of the MCQs and the test what we give. Bye bye, best of luck. Thank you very much, and I'll see you soon in the upcoming lecture.